Hey everyone, Dr. Steve here. You know it as well as I do, but most students need a B or better in A&P. But did you know that students are doing that all over the US using my Anatomy and Physiology Digital Suite as a low-cost alternative to expensive textbooks? Digital Suite delivers the key concepts of A&P with short, assignable tutor videos and a bulleted narrative study guide that not only explain the concepts of A&P, they show them happening. Combined with state-of-the-art dissection and physiology lab simulations and a vast question bank for quizzes, homework assignments, and exams, Digital Suite meets students where they are and gives them the tools to master the content. It's the perfect supplement to an OER textbook or just on its own. If you're an A&P instructor, contact your McGraw-Hill representative today and ask about Anatomy and Physiology Digital Suite. If you're a student, tell your instructor about it. There's a link to Digital Suite in the show notes of this episode. Get your B or better in A&P with A&P Digital Suite.
Every team, every topic, everywhere. This is Believe.
Hey everyone, welcome back to my podcast, Anatomy and Physiology Bit by Bit. I'm your host, Dr. Steve Sullivan, coming to you from Bucks County, Pennsylvania, just outside of Philadelphia, where I've been teaching A&P since 2002. The main focus of this episode is prostate cancer, one of the most diagnosed cancers in men. The prostate is a gland found in biological males only. It is just inferior to the urinary bladder, surrounding the most proximal segment of the urethra. Its secretions contribute to seminal fluid. You can learn all about it in episode 69 of this podcast, which covers the male reproductive system. Although many prostate cancers grow slowly and may never become life-threatening, others can be aggressive, spread beyond the prostate, and require timely treatment. For patients and their families, a diagnosis can raise difficult questions about screening, treatment options, urinary function, sexual health, recovery, and what life will look like after cancer. So let's talk about prostate cancer a bit before we get to today's special guest. As always, please remember that this podcast is for educational purposes only, and nothing said in this or any episode should be taken as direct medical advice. If you or someone you know is experiencing any signs or symptoms of anything you hear about in this show, please contact a medical professional as soon as possible. This episode is especially personal for me. I was diagnosed with prostate cancer in November of 2025. I had no signs or symptoms. In October, I simply went to my general practitioner for a routine annual checkup and blood test. The blood test showed an elevated PSA, which stands for prostate-specific antigen. And we'll discuss that later in the episode. I was referred to a local urologist who examined me further and ordered an MRI of my pelvis. That MRI showed a mass on my prostate, so then I had a biopsy. Several tissue samples were collected from all over my prostate, called core samples, and examined by a pathologist. The result was positive for prostate cancer. I want to take the time to acknowledge a couple of people. First is Dr. Radhika Ragam of Penn Urology in Doylestown, Pennsylvania. Dr. Ragam was the first urologist I saw and gave me my diagnosis. She is an amazing doctor and did everything needed to make sure I was on the right path. Ultimately, I chose to go to Fox Chase Cancer Center for two reasons. One, my wife had a very positive experience there with her breast cancer treatments. Two, a lifelong friend of mine, Dr. Mark Cohen of Memorial Sloan Kettering Cancer Center in New York City, recommended a specific surgeon at Fox Chase. We'll get into that in a bit, but first, more on prostate cancer. Cancer cells in the prostate are graded, and based on that grade, given a score called a Gleason score. The Gleason score describes how abnormal prostate cancer looks under a microscope and helps estimate how likely it is to grow and spread. It is a measure of the cancer's grade, not its stage. Stage describes where the cancer is located and whether or not it has spread. My prostate cancer breached the prostate's capsule and began to spread into the seminal vesicles, which are right next to the prostate. However, the lymph nodes were clear, so it was considered stage 3. A pathologist examines prostate tissue obtained from the biopsy or surgery and identifies important patterns in the cells to help determine treatment options. The patterns are referred to as pattern 3, 4, or 5. Pattern 3 means the cancerous cells are still relatively well formed and resemble normal prostate cells. Pattern 4 means the cells are poorly formed, fused, irregular, or arranged in more complex patterns. And pattern 5 means the cells have largely lost their glandular organization and appear highly abnormal. The grade of the most common pattern is written first, followed by the grade of the second most common or next most significant pattern. The two numbers are then added together. For example, a 6. A 6 is a 3 plus 3. It means the cancer consists entirely or almost entirely of pattern 3 and is generally considered lower grade. This is the lowest Gleason score typically reported. There are two 7s. First, you have a 3 plus 4 7. This means that most of the tumor is pattern 3, but some pattern 4 is present. This is what I had. It's usually not a particularly aggressive cancer type. Second is a 4 plus 3 7, meaning most of the tumor is pattern 4. Although the total is also 7, this cancer has generally a less favorable outlook than a 3 plus 4 tumor because the more aggressive pattern predominates. Any score higher than 7 represents high-grade cancers that are more likely to grow rapidly or spread to other parts of the body. The Gleason score is only part of evaluating prostate cancer. Physicians interpret it together with the PSA level, tumor stage, imaging results, number and percentage of positive biopsy cores, surgical margins, and other pathological findings when considering treatment options. Since I was only 53 years old at the time, which is on the young end of the age range for prostate cancer, the recommended treatment for me was to remove the prostate and adjacent structures completely. So in January 2026, I underwent a robot-assisted laparoscopic radical prostatectomy. This is a minimally invasive surgical procedure in which the entire prostate gland, seminal vesicles, and some nearby pelvic lymph nodes are removed. While I was under general anesthesia, my surgeon made 6 small incisions in my abdomen and inserted a camera and slender surgical instruments attached to robotic arms. In this procedure, from a nearby console, the surgeon controls every movement of the instruments. The robot does not operate independently. I remember thinking robot-assisted surgery and imagining C-3PO was scrubbing in. In this procedure, the prostate is carefully separated from the bladder, urethra, surrounding blood vessels, and nearby nerves. After the prostate is removed, the bladder is reconnected to the urethra. The removed tissue is then examined by a pathologist to assess the cancer's extent and determine whether the surgical margins are clear of any cancerous cells. My surgery was successful and the margins were clear, and since then, all of my blood tests have shown an undetectable PSA level, which is ideal. I'll be monitoring it for several years to make sure no cancer cells remained in my body and began to multiply. Non-surgical treatment options we discussed are radiation therapy, which destroys the prostate tissue, and hormone therapy, which blocks testosterone, which prostate cells need. These are sometimes done in lieu of surgery or in conjunction with surgery. Luckily, I didn't need to do either of those. Some patients are also candidates for targeted proton therapy, more commonly called proton beam therapy, which is a form of external radiation treatment that uses protons to destroy prostate cancer cells. My urologic oncology surgeon was Dr. Alexander Kutikov of Fox Chase Cancer Center in Philadelphia, and he is my guest today. Dr. Kutikov is a board-certified urologic surgical oncologist and the chair of the Department of Urology at Fox Chase Cancer Center in Philadelphia, Pennsylvania. He is also the co-executive director of the Fox Chase Temple University Urologic Institute and holds the Roberta R. Scheller Endowed Chair in Urologic Oncology. Dr. Kutikov earned his medical degree from Harvard Medical School, completed his urology residency at the University of Pennsylvania, and went on to complete specialized fellowship training in urologic oncology at Fox Chase Cancer Center. His clinical work focuses on cancers of the prostate, kidney, bladder, adrenal glands, testes, and other organs of the genitourinary system. He is recognized not only for his expertise in traditional and minimally invasive surgical procedures, but also for helping patients understand their options and participate meaningfully in decisions about their care. In our conversation, we discussed many aspects of genitourinary cancers, and when this is the topic, Dr. Kutikov is simply the foremost authority in the Philadelphia metro area and beyond. As both an anatomy and physiology professor and a prostate cancer patient, I approach this discussion from two perspectives, the scientific and the personal. I hope that sharing what I have learned and speaking directly with the physician who treated me will make this complicated subject more understandable and help patients feel better prepared to ask questions and take an active role in their care. So having said that, it is my honor to welcome my surgical oncologist, Dr. Alexander Kutikov, to the podcast. Okay, Dr. Alexander Kutikov of Fox Chase Cancer Center in Philadelphia, thank you so much for joining me.
Thanks so much for having me here. Really appreciate it.
Well, I'm very excited to talk to you about something that is actually pretty close in my mind most of the time now. But before we get started, if you don't mind, let the listeners know who you are and what you do.
Yeah, absolutely. My name is Alexander Kutikov. I'm chair of urology at the Fox Chase Cancer Center, and I'm co-executive director of the Fox Chase Temple Urologic Institute. I'm a surgeon who takes care of urologic cancers. Mainly those are prostate cancer, kidney cancer, bladder cancer, testicular cancer, and other oncologic problems of the urinary tract. The goal is to help patients to receive evidence-based care, individualized care, and we take care of a lot of folks in the Philadelphia region.
So you specifically deal with cancers, or do you do things that a general urologist would do as well?
Yeah, I'm a urologic oncologist. My practice is really centered towards cancer, but urologist really takes care of diseases of the urinary tract, both for men and women, and also diseases of the male reproductive system. And urologic oncologists are folks who've done an additional fellowship and really just focus on the cancer part. Although, I obviously I'm trained as a urologist. I will take care of the kind of the trivial things that are urologic, but I have a large group of partners who really focus and fellowship trained in each specific area of urology.
Okay. So that's a good distinction when people hear urologist or they hear uro-oncologist. Sometimes I hear that term. So for the listeners to know the difference between those things is good for them, I think.
Yeah. It gets a little complicated just to sort of piggyback on that. There's GU, general urinary oncologists, which are medical oncologists, not surgeons that, I partner with who give chemotherapy, immunotherapy, those kind of agents. And they don't do surgery. They medically treat cancers. And then there are also GU radiation oncologists who are radiation docs who give radiation therapy to patients with urologic cancers.
Okay. So there's a team.
There's a team. Absolutely.
And I think we're going to talk about that a little bit later because that's been a pattern with most of my guests of late. So if I could just go back into the past a little bit, what drew you into medicine and specifically what made you choose urology and urologic oncology as your specialty?
Yeah, I mean, we actually it's funny. Just this week we have a large high school program that we have in the Urologic Institute where high school students who are interested in medicine come and they rotate with us and they join us in the operating rooms and the clinics and kind of get exposed to medicine. And our docs and trainees basically have a structured program for them for the summer where they learn how to drive a laparoscope and a cystoscope and how to tie knots and see the surgical robot and all those kind of things. So a really great kind of summer for them to get exposed to medicine. But one of the sessions we just had in our grand rounds in the morning is why did you choose medicine? How what are the right reasons and the wrong reasons to choose medicine? And the one thing that we heard from a lot of the trainees, a lot of the docs, physician assistants is really medicine is a calling. I mean, it is one of these things where you gotta, I cannot remember myself wanting to do anything else. And I've always wanted to be a doctor. And I think those are the folks that are happiest in medicine, where they went to it for the right reasons. They wouldn't want to do anything else. Not a single thought where I should have done something else. This is the only thing I've ever wanted to do. It is one of these things I think you're almost born to want to do. I think medicine only works out when it's kind of your calling in life.
Yeah, for sure. I remember years ago I was doing some side work for a company up in New Haven, Connecticut called Covidian. They make surgical devices. and mostly staplers was their big thing, or at least the company they bought that I used to work for was making staplers. And I got to go up to their New Haven facility. I was teaching anatomy to their sales reps, and they had a laparoscopic simulator where I got to play with it and do a simulated cholecystectomy or something like that, and I got to play with it, and I had never touched anything like that before. So that was fun. It's cool that the high school kids get to do something where they get to expose to that. So for students learning anatomy and physiology, which is what most of my listeners are, why is your field such a natural intersection of anatomy, physiology, and pathology?
Yeah, I mean, few specialties really depend on anatomy and physiology like urology. The normal urinary tract function explains why diseases develop, how symptoms arise, and why treatments work. Really, understanding anatomy is incredibly essential for diagnosis and surgery in the urologic field. For instance, in general surgery, there's this concept called exploratory laparotomy. You kind of open up at somebody's belly to figure out what's going on in there. There's very little of that in urology. In urology, you really know what your plan is, what you're going to do before you get there, because imaging is so precise in the urinary tract. And you really do have a plan before every surgery, whether that's, operating on the kidney and finding that tumor and just taking the tumor and leaving the rest of the kidney behind, or reconstructive specialists in our field, what part of the ureter or UPJ, ureteropelvic junction of the kidney is affected and how you're going to repair it. Cancers of the lower urinary tract, everything sort of depends on planning, imaging, and understanding how the pathology relates to the normal anatomy.
Okay, that's important. I think that with a lot of fields, understanding that anatomy, especially when it comes to imaging, is so important because the challenge in the different kinds of imaging and being able to understand that you're looking often at a two-dimensional picture of a three-dimensional structure, and what views do we have and things like that can get pretty challenging. So when we talk about urologic cancers, we hear all the time, we hear prostate, bladder, kidney. What are the most common, and how can they differ from one another in terms of what the patient might have as symptoms, what are risk factors, and treatments?
Yeah, I mean, there's just vast differences between these cancers. The organs are embryologically different, physiology is very different, and the risk factors for these cancers are different. And just to kind of get a little bit nerdy and academic about it, for instance, prostate cancer is the most common cancer in men. Over 300,000 men in the US get diagnosed with prostate cancer. The prostate basically secretes ejaculatory fluid that, is important for fertility. Most of the fluid actually comes from seminal vesicles, and the seminal vesicles never get cancer, although that epithelium turns over much more rapidly than prostatic epithelial, whereas prostate develops cancer in a large proportion of men. So sort of the body has these mysteries where we don't quite understand, where you think it's the epithelium that would turn over the most. No, in the genital urinary tract, I've seen probably 2 seminal vesicle cancers in my entire career, and I see cancer every day, whereas prostate cancer, my clinic is full of it. The bladder cancer is a very different cancer than prostate. It's a cancer of the transitional epithelium, the inner lining of the bladder. There's a huge wide spectrum of aggressiveness in bladder cancer, just like in prostate cancer and just like a kidney cancer. And that's one of the, just as a quick aside, that's one of the biggest responsibilities of an oncologist, is to calibrate and tailor the intensity of treatment based on the kind of cancer a person has. So, half the prostate cancers that I see, I tell people that they don't need to have it treated. Whereas the other half, there's, a whole sort of spectrum of intensity with which we treat it. Bladder cancer is a fascinating cancer because it's a field defect. Once you have a cancer in the inner lining of the bladder, you can have a cancer. You're at risk of a cancer in the inner lining of your ureter or the inner lining of your kidney. So it's a cancer where somebody with bladder cancer, we have to watch their ureters and kidneys for the rest of their life. When we talk about kidney cancer, you can have a urothelial cancer in the kidney, which is sort of a relative of bladder cancer, but most of the cancers in the kidney come from the meat of the kidney, which is a renal cell carcinoma. And then in the renal cell carcinomas, there are a whole, variety of different renal cell carcinomas that, you can have. And in each of the subtype of renal cell carcinomas, there's different grades or different aggressiveness of that. So there's a ton of complexity. Also, as a urologist, take care of adrenal cancers and adrenal disease, which is also kind of, it's a fascinating field in itself. So, I'm very fortunate to sort of be able to kind of, help lots of folks with lots of different problems. I really love that variety. Some surgeons really just focus on one thing. I actually think the cross-pollination of different skill sets makes me a better surgeon in a particular space for, so for instance, I do a lot of kidney and prostate surgery. I think it makes me a better prostate surgeon because I know how to operate on the kidney and vice versa. So I really love the field I entered. It's just fascinating. It's rapidly changing. I get to be sort of a lifelong scholar and have to learn new things, almost every week. So
Yeah, I can't even imagine having to do that. That seems like a lot. So you've got my histology wheels turning a little bit with some of the things you said in there. So I'm gonna come back a little bit to what you mentioned. You talked about bladder cancer and having to worry about ureter and urethral cancer. Is this because of the transitional epithelium that extends throughout?
that's right. Transition epithelium, again, it's sort of this field defect. Once you develop a cancer and it looks like all the other transitional epithelium in your body is susceptible to developing cancers. So you got to monitor people carefully.
Okay. And just for the listeners, I just want to let you know, if you want to go back and review epithelium, you're going to have to go way back in the podcast to one of the first 15 episodes. And I'll talk about transitional epithelium, which is also known as urothelium, and what happens to those epithelial cells when they sometimes look cuboidal, sometimes look squamous. One of the epithelia that my students have the hardest time identifying in class. You mentioned all these different kind of cancers that you treat. I'm really intrigued by the adrenal. I'm assuming, is that just geography?
Yeah, so it's, there's several specialties that treat the adrenal gland. Back when I was a fellow, I happened to write a chapter in a textbook, and then I got invited a little bit later on to write sort of the main chapter in our kind of Bible textbook of urology, Campbell's Walsh Ween Urology. And so I've been writing that chapter with my co-authors for pushing 20 years now. And sort of that academic interest, I've written papers in the adrenal space, but that had translated into sort of a referral pattern where folks in the city send me adrenal cases. I understand the disease. There's actually a lot to know how to work it up and which patients to operate on, which not. I always say that, decisions override incisions any day. You got to make the right decision. If you're taking the wrong people to the operating room, then that's sort of a definition of a poor surgeon. In the adrenal space, a lot of patients that see me, I basically kind of work them up, figure it out, and tell them they need nothing. But when you do operate an adrenal gland, it lives right next to the kidney. I do a lot of retroperitoneal, upper retroperitoneal surgery. So if fortunate enough to have been trained in all the techniques, and we have a premier fellowship here at the Fox Chase Temple Urologic Institute where, I tell them you come here and you'll be able to face a patient for the rest of your career and sort of not be tied to this or that modality. You're going to be a great robotic surgeon, great laparoscopic surgeon, and a great open surgeon, especially for the adrenal gland. That's important. For instance, adrenocortical carcinoma, once it's over 6 centimeters, despite the fact that you can be the best robotic surgeon in the world, there is good evidence that it's just too high risk to do those cases minimally invasively because just the way you manipulate the tissue, this is a very friable mass, which is very easy to spill. So those cases we actually do with an incision because it's much easier to handle those tissues in a very delicate fashion and lift the tumors without spillage through an open incision. And those are international recommendations. And some surgeons, these days are just not comfortable doing open surgery, and they send those folks to us. Adrenal is actually fascinating. It's one of my favorite disease sites because there's a lot of physiology, there's a lot of endocrinology, and there's surgery.
And it's like 2 glands in one.
Oh yeah. Medulla, cortex, absolutely.
Yeah, they're completely different. I would imagine that an adrenocortical tumor would cause something like Cushing's disease.
Yeah, about 20%. The carcinomas are very rare, but there are a lot of benign ones that just produce either cortisol or aldosterone. The hypersecretion of androgen is very rare, but I've seen those patients. That's a really rare bird. Pheochromocytomas are the tumors from the medulla. They're not uncommon. They're very satisfying. A quick surgery cures somebody of terrible hypertension, terrible symptoms. Yeah.
I want to get into prostate cancer a little bit. It's so common. It's kind of like breast cancer in women. Everybody knows someone who's had it. You mentioned a little bit about what the prostate does. If we could just talk a little bit about the prevalence of prostate cancer, maybe why that is what it is, and how does it get detected? How does it typically develop?
Yeah, so prostate cancer, as I said, is quite common. It affects over 300,000 men each year in the United States. It is a cancer that becomes much more common after age 50, although plenty of 30 and 40-year-olds can be affected. The biggest risk factors are family history, and there's some genetic predispositions like the BRCA gene, some other genetic conditions that are hereditary. These days, the most common way to find prostate cancer is through prostate cancer screening. It's through checking one's PSA. The general recommendation is to check PSA after age 50. That sort of decision is complex. There are different medical societies actually have different recommendations for prostate cancer screening. And why is that? Because PSA, well, first of all, what is PSA? PSA is this protein that is produced by prostate cells, and it is not a cancer test. It is rather a marker that helps estimate risk, which is important to understand. And it's basically this protein lives inside prostate cells, and it gets released at a very low level into the bloodstream, and the cells can become more leaky. They can become more leaky because of inflammation. They can become more leaky because of cancer. And also, you can have a higher PSA level because you just simply have a bigger prostate. You have more prostate cells. So it's very nonspecific. A PSA elevation is very nonspecific. And prostate cancer treatment and prostate cancer detection, I always tell patients, is an investment 10, 15 years from now. So some men, have medical problems where their life expectancy is just not going to be past 10, 15 years. For instance, somebody in their 80s who may be healthy, but they're just unlikely to live past age 90 or whatever it is. And finding a prostate cancer at that age, it's just a disservice. It really is not, it's just going to decrease your quality of life now. It's going to make you worry. It's going to sort of force you to treat some things that were never destined to get you into trouble. So prostate cancer screening is generally not recommended past age 70. There are exceptions, obviously, men with strong family histories, men who are in exceptionally good health, but those are personal decisions. And so when we talk about screening with PSA, we talk about this concept of overdiagnosis and overtreatment. And the way we mitigate it is we screen the folks that need to be screened, and we treat only folks who need to be treated. It's important to sort of not find every cancer and treat it, because some of these low risk cancers, actually, we're talking about risks of 1 in 1,000 over 20 years of having a prostate cancer mortality, which is, incredibly small, and the chances of getting into trouble with treatment are higher. So it's an interesting space because there's a lot of critical decision making, a lot of balance, a lot of counseling. In my job, a lot of men that see me already have a diagnosis. So my job is to de-escalate care, where I see a lot of men that come for surgery, and I should tell them, listen, knowing everything I know, if I was in your shoes, I actually would just wait and just, let's keep an eye on this. And, we do a lot of active surveillance at Fox Chase. The standard is after age 50, annual screening. That's kind of the general guidelines from the American Urological Association. Generally, it's annual, but if the PSAs are low, there's now lots of sort of conversations about de-escalating that and skipping some years. There's not a huge wide consensus. There's the opinions, but especially somebody has a first degree relative who is healthy. Annual screening is appropriate.
I get that a lot of prostate cancers are found asymptomatic, which was the case for me because I got the PSA checked, and that's how we found it. What signs and symptoms should people be looking out for to say, hey, you got to get this checked out?
Yeah. So prostate cancer symptoms actually really late onset for patients whose disease is localized. It's things like lower urinary tract symptoms, where, more frequent urination, poor stream. The problem with that is that a lot of those symptoms are actually not due to cancer. It's the more common pathology in the prostate is BPH, benign prostatic hyperplasia, where it gives you these symptoms of weak stream and frequency and lower urinary tract and bladder dysfunction just from benign growth. But if you're having those symptoms, it's important to get checked out because it could be from a cancer. Blood in the urine is a huge trigger for seeing a doctor. I mean, if you have blood in your urine, it's very important to seek medical care. It could be a harbinger of a big problem, both in your prostate, in the bladder, in the kidney. It can be just a kidney stone. It can be a lot of benign things, but it can also be cancer in your kidney, in your bladder, in your prostate. And the tricky part is that you can have blood one day and not have blood again for many months and weeks. And ignoring that one episode of hematuria can really delay a very important diagnosis and really can change destiny. So if your listeners take anything away from this podcast is you hear of a loved one who has blood in their urine or you have blood in the urine, get it worked up. Again, a lot of the times it'll be absolutely nothing like a urinary tract infection or kidney stone, but sometimes you can early diagnose a cancer that's very important to catch before it spreads.
Yeah, that's good advice. It's good to know when there's something like that and someone will see it go away and figure, okay, good, I'm good. But that might not be the case.
Correct. Going away is not good. The way, for instance, the cancers bleed is that the cancers, when they grow, they have these very friable blood vessels that they recruit in order to feed the cancer to give it oxygen. And those ones are more likely to pop than normal blood vessels. But those stutter. They can, you can have a blood vessel that's sort of on the surface and pops, and you don't have another blood vessel that doesn't pop for another year, and you'll miss that opportunity.
Well, that is good to know. I had a guest on a couple of weeks ago talking about multiple sclerosis, and her big sign to never ignore is eye pain. Eye pain is an immediate doctor visit. Never ignore eye pain. So anyway, you just reminded me of that because this is something that people should never ignore. So you also talk about, you mentioned bladder cancer. We talked about that a bit and what to look for. Kidney cancer is something you don't hear about as much as other kinds of cancers. What are people looking for? What kinds of kidney cancers are there, and what are the typical treatments for that?
Yeah, so kidney cancer is actually, it's not too uncommon. It's, 60 to 80,000 people a year get kidney cancer in the United States. The most common cancer is renal cell carcinoma. Again, it's the cancer that's from the meat of the kidney. The treatments for kidney cancer, for localized kidney cancer, are very much surgical. It is either a radical or a partial nephrectomy, where in the past we used to always just take out that whole kidney. We used to say, hey, you got one brain, now you'll have one kidney, no big deal. But these days, our priority list is first, take out the tumor, second, try to save the kidney, and third, do it minimally invasively. And a lot of the surgeries that I do is a minimally invasive robotic partial nephrectomy, where I go with small little incisions. I go in, I move the colon over, I find the renal artery, I put a clamp on it, and I cut out a piece of kidney. There's a lot of techniques to sew up the kidney, and then I remove the clamp. And one thing that I do that we pride ourselves here at Fox Chase is for patients whose tumors are on the backside of the kidney. So we're talking about anatomy, where just, location really matters, because if the tumor is on the backside of the kidney, especially if it's behind the blood vessels, you have to flip the entire kidney. It's a very, release the adrenal. It's hard to get there. You don't have good line of sight onto the tumor. It's hard to cut out. So we do what's called retroperitoneoscopic robotic surgery, where we actually enter through the side and go behind the kidney and expand the retroperitoneal space with a balloon and kind of dock the robot behind, and then it becomes a very simple case where you're just staring at the artery, staring at the kidney, and staring at the tumor from the back, and you can have very good visualization. A little bit less space there, so all things being equal, we try to do it transperitoneally, but for these posterior tumors on the kidney, we do retroperitoneoscopic surgery, and it's a really nice approach. Now, kidney cancer, out of all the localized kidney cancers, some of them do come in and they're much more advanced. They're kind of taking up a lot of the kidney, and then we take out the full kidney. A lot of that I do just pure laparoscopically without the robot. You really don't need the robot to remove the whole kidney. Kidney cancer does, in some patients progress to systemic disease, and there's been a complete renaissance in kidney cancer. It's a cancer that actually is very resistant to chemotherapy and very resistant to radiation. So we didn't have a lot to offer to patients whose kidney cancer has spread, and kidney cancer has been on sort of the vanguard of these new therapies. So targeted therapies where you basically we talked about the blood vessels that grow into cancers. The kidney cancer is a very oxygen hungry cancer. It really needs those blood vessels. So these VEGF mediated pathways where the tumors are communicating with endothelial cells and making the blood vessels grow into the tumors, we now disrupt them with these tyrosine kinase inhibitors that are very effective for kidney cancer.
Oh, that's neat.
Yeah, and you disrupt that communication, and you basically suffocate these tumors because as they grow, they can't attract the the growth of the blood vessels into themselves. And then the other powerful tool that we have for kidney cancer is immunotherapy. It's very immunogenic. So all these PD-1 inhibitors, PD-L1 inhibitors, CTLA-4 inhibitors work really well for kidney cancer. And so kidney cancer and melanoma have been sort of the primary cancers where immunotherapy was initially investigated and shown to work. I should mention this as far as anatomy. So at Fox Chase, I was very fortunate. My mentor Rob Uzo, when I came to do a fellowship with him, I came and I said, "Wow, we're doing all these partial nephrectomies, and people publish. I did 100 partial nephrectomies, and I had this complication. But all partial nephrectomies are not the same. Some of them are very complex. These tumors are kind of in the middle of the kidney. It's related to all the blood vessels and collecting system and all those things. Where some things are hanging right on the surface of the kidney. And there's no really way to describe how the tumor relates to normal anatomy. And we sort of work together to propose what's called the renal nephrometry score. It's one of the most referenced papers in the kidney cancer space over the last 2 decades, where kind of surgeons all throughout the world use it to describe their partial nephrectomy series, their radical nephrectomy series. There's been correlations with pathology, with complications, with all these things. This is sort of a standardized communication tool now on how to describe the way a tumor relates to the rest of the kidney. It stands for renal is radius, endoexophytic, N is nearness, A is anterior posterior, and L is location, how it's related to the poles versus the center. So
oh, that's great. That probably makes it easier, especially when you're one member of a team, so that you can communicate exactly to the other team members what you're dealing with.
absolutely. Yep.
So speaking of that, we mentioned this a little bit earlier. You talked a lot about the surgical approach to the cancers, which is mainly what you do. So who else is on the team, the treatment team, that you are communicating with for any one given patient?
Yeah, I mean, there's a lot of team members. I think the oncologists we mentioned, those are the, surgical oncologists, which in urology is urologic oncologists. There's the medical oncologists, there's the radiation oncologists, right? But there's, especially at a comprehensive cancer center like here at Fox Chase, I mean, there are key members that really make a huge difference. For instance, radiologists. Not every radiologist is created equal, and I have my favorite radiologists where some of the scans that I want to review, I review with kind of key members of that radiology team to find things that maybe a radiologist on the outside didn't find. Pathologists, hugely important. I mean, there's so much nuance. There's so much that depends on an accurate pathology read. A lot of decisions pivot on that. So pathologists are super important. Advanced practice providers, I can't be everywhere at once. I have physician assistants and nurse practitioners who work with me who are critical members of the team that help, extend me. I mean, they're physician extenders, and we at the Institute really have a very large team now that is an extension of us. They've trained with us. We actually have a national course now for advanced practice providers for urology. They're such an important part of the team now. Our nursing teams are key. This is a magnet hospital where I think without our nurses we couldn't do what we do. I think they're super critical, and very fortunate here in Northeast Philadelphia where we practice. Fox Chase Nursing they take so much pride in being a Fox Chase nurse. A lot of it sometimes second, but sometimes third generation. Grandmother was a nurse at Fox Chase, and it's you can write a lot of papers and you can have a lot of titles, but you're only as good as your last case, as your last patient, and the nurses keep you true to that. So there's a mantra around here is patients first, and they make sure that the docs and the APPs live by that every day. Nothing matters more than the patient care that we provide. They're the pharmacists, the nutritionists, the social workers, genetic counselors, physical therapists. There's the clinical research team. It's a huge team. And everybody's important.
Wow, that's a lot of people. I will say this was an interesting coincidence, but after you performed surgery on me back in January, the nurse that I had while I was still at the hospital was a former student of mine.
Oh, is that right?
Yeah.
I didn't realize that. How about
Yeah,
that?
about 10 years. I think it was about 10 years ago, she took my anatomy and physiology class. That was an
Well,
interesting
there you go.
coincidence
Talk about
that
paying
happens to
forward.
me.
Yeah,
But
yeah.
when you've been teaching A&P for 24 years, you're running into former students every time you walk into any medical situation.
That's so neat. Yeah.
There's so many of
Yeah.
them. I can't say enough about Fox Chase Cancer Center. It has been amazing for not only me, but for my wife as well. We are both been to Fox Chase Cancer Center. We have a lot of options in the area where we live, and Fox Chase Cancer Center was hands down the best choice for us 100%. So I love what they do over there. People like you, it's been really, really great.
That's a special place. I appreciate you saying that, but I think we're all very fortunate to live in Philadelphia, where I think the statistic is about 20% of every physician had spent, some point of their career in Philadelphia, whether it's medical school or residency training or fellowship or practice. It's a great medical city. I think, we're surrounded by some very good medical cities, like New York and Baltimore, but I just think Philadelphia medicine, the fact that there are options and the fact that everybody really takes pride in taking incredible care of patients. I think it's the competition between the hospitals is terrific for patients. I think, only the good docs actually end up doing what they're doing because there are just so many options here.
It is amazing. And most of my listeners also know from me mentioning it a few times that I've had rotator cuff surgery a couple of years ago. And I went to Rothman, and what a great experience that was as well. It's whatever the medical situation is, we have so many great options in the Philadelphia area. You're right. It is a great privilege to live in this region. Okay, last thing I want to ask you, and then I'm going to let you go. You've been super generous with your time. For students or future healthcare professionals that might be listening, what advice would you give someone considering urology, surgery, oncology, or even academic medicine as a career?
Yeah, I think stay curious. This is an amazing field. There's never a dull moment. There's so much that happens in every domain, whether it's, social interactions, whether it's the science, whether it's the challenges. You always need a strong scientific foundation. I think that, study. And, I think these days, I have children. I know you can go to AI and get an answer, try not to do that. Try to actually understand, because that's critical. Seek mentors who challenge you, not just to tell you that you did a good job, but actually challenge you and, sort of make you think critically. For students who especially go into surgery, communication matters. That's critical. Your humility matters. You got to be a lifelong learner. But for surgery, technical skill matters. And that's a skill that's really orthogonal to anything you've been selected on, which is tricky because you've been a good student, you've gotten great SATs, you got your MCATs, and then just you may not have that technical skill set to, be a great surgeon. In certain fields like urologic surgery, ENT, head and neck surgery, there's actually a medical part of that specialty where you can always pivot if that's not your strength and you don't have to be that, sort of high volume surgeon. But if you're kind of find yourself that maybe you don't have that skill set, maybe surgery is not for you. There's so many other specialties to go into. Academic medicine is rewarding every day because it really just offers opportunities to not only deliver the care, but actually improve care for, both today's patients and really tomorrow's patients, which is, super challenging and exciting in many ways.
Well, that sounds like great advice. I really appreciate you coming on. You've been so generous with your time and your expertise, Dr. Kutikov. I think the listeners are going to get so much out of this.
It's a real privilege. Thanks for inviting me, Steve.
Once again, a very big thank you to Dr. Alexander Kutikov and his entire team at the Urology Center at Fox Chase, not only for coming on the show, but for taking such great care of me. A special shout out to Dr. Kutikov's physician assistant, Elena Drazen, for providing excellent care and facilitating his appearance on the show. And to the surgical and post-surgical team at Fox Chase, from the anesthesiologists to the surgical residents to the nurses. I'm not going to lie, this was a difficult surgery to recover from, and the post-surgical nurses really knocked it out of the park. I did not anticipate how uncomfortable I'd be, and they were a huge help in managing my care. I also don't want to forget to thank Drs. Ragam and Cohen for their help initially in the beginning of this battle. And of course, thank you so much to my wife for taking good care of me at home after the surgery, to my kids for helping out, to all of the friends and family who sent food to help us out afterward, and well wishes and gifts and all that good stuff. Thank you so much. It really takes a village, and I am humbled by the number of people who came out to help. So thanks again, everyone, and thank you, the listeners, for supporting the show. I hope this podcast is helping you understand more about the human body and what ails it. And of course, I hope it's helping you get your B or better in A&P. Good luck, be well, and I'll talk to you next time. Anatomy and Physiology Bit by Bit is a production of Minus 55 Media and is hosted by the Believe Network. Please take the time to rate my show and leave a review. You can also check out the content I post on Instagram and YouTube as @StudentHelp4AP. That's the number 4 AP. Special thanks to my family, Bucks County Community College, and McGraw-Hill Education, where your instructor can find Anatomy and Physiology Digital Suite, my low-cost tutor video-based digital learning solution for anatomy and physiology currently being used at several colleges and universities. If your instructor isn't using Digital Suite, let them know about it. The link is in the show notes.
If you like the show, please take a moment to rate, review, and subscribe. It really does help the show to grow. Thank you for listening.